Hello, my name is Dr. Roberta Farias, and I'm the cornea head preceptor from the ophthalmology residency at Federal University of Maranhao in Brazil. I would like to thank the World Pediatric Congress for the invitation and show a bit of our work today, which was published on the ocular immunology inflammation last year. This is a case report over an 8-year-old boy that was referred to us with a supposed cornea ulcer treated for the last 8 months with fortified antibiotics in the right eye. This all began 2 years before, around 2013, he had presented inflammation of both eyes with frequent episodes of intense itching, photophobia, and cold body sensation. As personal background, he denied asthma, rhinitis, dermatitis, or any other systemic or allergic disease. His biomicroscopic examination showed a shield ulcer which was visible in the right eye with numerous bilateral papillae, numerous nodules of Trentus, and a degree of upper limbal insufficiency in both eyes. Due to this classic clinical find, we were sure of a vernal keratoconjunctivitis diagnosis. So, shield ulcer debridement and prednisolone acetate 1% eye drops were applied every hour with preservative-free artificial tears. Epinephrine hydrochloride eye drops twice daily were also initiated. And we also asked the patients to seek for an allergist. In 2 to 3 weeks, the ulcer resolved, but the papilla and Trentus nodules persisted, although in fewer numbers than before. So we decided to perform 3 injections of triamcinolone acetate on the upper tarsus, and topical tacrolimus ointment was also started. So the papilla, this is the same patient, the papilla completely resolved, but the Trentus nodules persisted. Allergologist follow-up was only started 1 year after our first eye consult, and he initiated oral systemic corticosteroid, oral sodium montelukast, and intranasal fluticasone propionate. Cyclosporin eye drops was also asked to be prescribed to the patient instead of tacrolimus ointment. He did a skin test for immediate hypersensitivity, as also known as prick test, which showed a sensitization to allergens of mice, dog, and cat. This means that he had hypersensitivity due to a Th2 pattern. So the patient received specific subcutaneous immunotherapy for the next 3 years, but with an atypically poor response. As his impaired quality of life continued with limited activities and no squamous, we proposed oral cyclosporin. So we decided to run some tests, blood tests on liver and kidney functions, which were within normal limits. The patient still did not progress to complete remission. 2 months after we start oral cyclosporin, his grandmother reported the illness and death of the patient's mother. So we decided to run an HIV serology test for this patient, which came out positive. Syphilis, hepatitis B, and C were all negative. So we referred him to the pediatric infectologist, and at this time his viral load was around 21,000 copies, and his CD4 was lower in compared to non-HIV infected people, but it was not significantly low. It was around 502. Interestingly, the patient did not present any other complaints, physical abnormalities, or recurrent bacterial, viral, or fungal infections since he was born. Antiretroviral treatment was recommended for his age group, which was started using tenofovir, lamivudine, and dolutegravir. 120 days after antiretroviral treatment started, the allergic symptoms have completely regressed, with only dry eyes secondary to his limbal insufficiency remaining. So a smile for the first time was present on his face. 8 months after, he had undetectable viral load and the CD4 count was above normal, 741. On his last exam on October 22, 2023, he had a CD4 still above normal, 640, and undetectable viral load. His spectral refraction, it was this, with a visual acuity of 2200 on the right eye and 2060 on the left eye. His biomicroscope examination showed diffuse corneal opacities on both corneas, worse on the right eye. Trancus and papillary reaction were all absent, and secondary dry eye due to superior and inferior limbal insufficiency more evident in the right eye. These are the pictures from his right eye, so we can see a normal upper tarso. Those are the corneal opacities on the right eye, diffuse corneal opacities, and this is the limbal insufficiency on the right eye. The left eye has also a superior upper tarsus normal. Corneal opacities are less dense, so we have a visual axis a little bit free of opacities, and his limbal insufficiency on the left eye was less intense than the right eye. So we decided to do a contact lens test to avoid corneal transplant, and his visual acuity was 20/40 partial on the right eye and 20/25 on the left eye. So right now he's using only tacrolimus ointment 2 times a day and trehalose preservative-free eye drops to improve his ocular surface. If this does not work on the next 2 months, we intend to do an autologous limbal transplant from the left eye to the right eye, and then do the contact lens tests again. What we learned from this case: first, I got to tell you, it was the most challenging allergy patient the allergist, specialist, and I faced over our 20 years of practice, so we will summarize you a bit of our work today. Vernal keratoconjunctivitis is very common in Brazil due to our weather, summer during most of the year, and it's more common in our region. We live in the northeast of Brazil, so it's summer all year around. It is more common on boys from 2 to 10 years old, and it has a tendency to resolve on puberty. The clinical signs are all the ones we presented on this case: giant papilla, trancus nodules, and shield ulcer. Hypersensitivity reactions involves type 1 and type 4 hypersensitivity reactions mediated by Th2 lymphocytes. HIV first patient was documented in 1983, so the next decade was marked by numerous studies over human immunobiology and HIV physiopathology. Normal human being has a balance between Th1 and Th2 levels, so they have a balance between cytotoxic T cell production and humoral response. On the other hand, HIV-infected people has a switch on the Th1, Th2 levels. They produce much more Th2 cells, and then they have a humoral response. They have an increased humoral response compared to the normal human being. And the allergic people, in the allergic people is observed the same thing. So we have on the allergic people increased Th2 levels and increased humoral response levels. So allergic and HIV patients has the same physiopathology concerning Th2 and humoral response. So IL-4 will be increased, and this will increase the B cells production of IgE. IL-5 will be increased, and this will increase the levels of eosinophils. But only on HIV patients, the IL-4 will induce on the T cells the expression of the co-receptors of HIV, which induce the viral replication. And if the CD4 is very low, this contributes to increase the IgE. And whenever they contract AIDS, it induces the loss of IL-2 and interferon, increasing the levels of IL-4. And if we increase the levels of IL-4, we increase the viral replication on those patients. Chronic allergic conditions may manifest as a spectrum of anterior eye surface disease caused by persistent allergic stimulus or by progression of the immune response regardless of the specific allergen. So in this patient, we observed that he had a progression of the immune response due to the presence of HIV infection. This means that viral protein expressions were the stimuli for his immune response. When there is a significant drop of CD4 cells in HIV patients, there may be a change in the response pattern of the lymphocytes from Th1 to Th2. This results in the production of cytokines IL-5, IL-4, and IL-13, among others recruited from mast cells and other cells, triggering the allergic inflammatory progress. Emphasizing the idea, we do know now that on vernal keratoconjunctivitis patients, we can find increased expression of Th2 cells and its cytokines on the conjunctiva of those patients. And the same thing is presented on the conjunctiva of the HIV-infected people. So whenever we treat HIV, we will increase the levels of CD4 and we will decrease the levels of IgE, controlling the disease, controlling the symptoms of the patient. So this case reports suggest that we must consider investigation of HIV infection in patients with refractory allergic conjunctivitis. Such qualification is a result of the Th1, Th2 deviation with Th2 increase that occurs naturally during the allergic process, and it is exacerbated by the Th2 increase caused by CD4 count reduction in the HIV patient. Thank you very much for your patience. Those are some pictures from my state, Maranhao, in Brazil.